Botox for treatment of infantile esotropia. As you've seen, Botox has gained a lot of popularity as an alternative treatment for infantile esotropia. It's produced by Clostridium botulinum, and it causes temporary paralysis of the muscle by preventing the release of acetylcholine from the nerve terminal. So it has an action similar to a recession. In esotropia, it can be used as a primary injection treatment without any surgical recession procedures, or it can be used as an adjuvant to a surgical treatment where you will inject and perform a recession together, or it can be used in secondary procedures to consecutive deviations. And I note that I did not say residual esotropia because you cannot inject the residual ET where the muscle is already recessed. You cannot be able to localize it. The action after inhibiting the injected muscle, this allows the regaining of the function of the antagonistic muscle. So if you inject the medial rectus, it becomes lax and allows contracture or regain function of the lateral rectus. The most important factor is that the patient sensory mechanism plays an important role in regaining the realignment. If the patient develops some form of binocular vision, then this ocular alignment may be maintained throughout life. So the development of binocular vision is therefore closely related to the patient's age. The success rates have varied from 36 to 78% and are related to the degree of strabismus and the age of intervention. There is a critical age where the medial rectus is more sensitive to this chemodenervation induced by Botox injection, allowing the antagonistic lateral rectus muscle to regain its function. So if the patient has been esotropic for many years with contracture of the medial rectus, this makes your success rate slightly less than if intervention had been at an earlier age. So early treatment provides a self-adjusting sensorimotor mechanism where the motor alignment allows binocular development, and this allows the maintaining of sensory alignment, and vice versa if true. If the patient regains binocularity and his sensory alignment is maintained, he will maintain his motor alignment. There is no fixed dose of about how many units to use for prism diopters through the many researches that have been made, but the range is from 2 to 15 units, and the most popular amount to be used is 2 to 5 units. The maximum action is expected to occur within 2 weeks, and the drug starts to wean after 3 to 6 months. So the larger the deviation, the more units that are needed to be injection, but obviously with limit. Usually, bilateral medial rectus are injected. An interesting observation was found that if you have the association between the dose of Botox injection and the success rate, it was found that if you inject higher amounts of Botox, you actually have a lower success rate. But probably this is related to the use of higher doses of Botox because they are used in larger angles of deviation. And through researches, it was found that Botox works best with deviations less than 30 prism diopters. So are we going to use an EMG guidance, and is it going to be an open sky or a closed sky? EMG guidance is very useful in adults. It allows us to perform the procedure in an outpatient clinic. The patient is awake, he can move his eyes, and we're able to track the signal through the EMG. However, in children, this is not possible because EMG signal is abolished under general anesthesia, with the exception of the use of ketamine, which is not used anymore. So in children, with the patient under general anesthesia, you have the option either to open the conjunctiva or to keep it closed after acute localization of the muscle and inject the Botox. So we had a study in the Cairo University and Pediatric Ophthalmology and Strabismus unit where the first group underwent a fixed bimedial recession of 4 millimeters, and we injected Botox in the same setting of 2, 2.5, and 3 units for angles of 45, 55, and 65 prism diopters. This was compared to a group that underwent conventional bimedial recession according to the Kenneth Wright nomograms. This is a short video displaying the technique. After opening a fornix conjunctival incision and localizing your muscle and suturing and stabilizing as a normal recession, the hook is used to put the muscle on tension, and so you can allow visualization, and then you inject your Botox unit in the middle and posterior aspect of the muscle. Q-tips is left for a few seconds to prevent the muscle from the toxin from dispersion, and then you would disinsert your muscle as you would do in a regular recession, but the procedure is much easier because you're going to perform only 4 millimeters of recession and secure the muscle at 4 millimeters from your insertion. This is a case of Esotropia 55 prism diopters. 1 month postoperatively, the patient has a slight consecutive XT. At 3 months, the patient is orthophoric, and at 6 months, orthophoria is maintained. This is another case. Unfortunately, I don't have the pre-op picture, but first day postoperative, the patient looks well aligned, but at 1 month postoperative, the patient has a consecutive XT. At 3 months, the patient is, although horizontally orthophoric, there's a mild vertical deviation, but at 6 months, the patient is both vertically and horizontally orthophoric. So we concluded that 2 units of Botox bilateral medial rectus injection can correct approximately 20 to 25 prism diopters. That means if you want a nomogram, it would be probably that 1 unit of Botox can correct approximately 5 prism diopters of deviation in cases of esotropia. The advantage of this study was we had comparable results, not only comparable to the previous researchers, but also comparable results to the control group that underwent conventional recession. We made injection and surgery in the same setting, so therefore the patient was not exposed to more than 1 operation and general anesthesia. The surgical number was also uniform, and this made it technically easier for the surgeon. We only performed 4 millimeters of recession, which is easier for the surgeon and also gives a safety margin for the preoperative assessment of the angle of deviation, especially in this age group, which is very difficult to assess. Last of all, the injection was made only once. We did not have to repeat more than once. The complications not related to the study but related to any patient injecting Botox is the transient ptosis. And let's say that this is not amblyogenic in the pediatric age group because the patient is able to assume an abnormal head posture, which allows him to continue his binocular vision. The consecutive XT, it's seen by many as a deviation. However, I've come to see it as a sign of success because patients who develop a consecutive XT will pass into orthophoria by the end of 6 months, whereas patients who have a residual esotropia or even orthophoric in the immediate postoperative period, they tend to pass into esotropia once again. The limitation of ocular motility, and this is also temporary due to the paralysis of the muscles injected, the vertical deviations that may occur due to leakage of the drug to surrounding muscle, and again, this is probably seen more in children because of the prone position in which we inject the muscle, and that even in the immediate postoperative period, they're still lying on their backs, so this allows the toxin to diffuse to the surrounding muscle. The residual esotropia that may still be present, and very rarely scleroperforation. So to sum up, Botox injection can be used as an alternative to surgery. It is less time-consuming and easier to perform. It allows early intervention at a younger age group and gives you a safety margin if you have not measured your angle accurately. It keeps surgery still a viable option, but you have to explain to the parents post-operatively what to expect regarding ptosis, consecutive XT, and limitation of ocular motility. So the question would be in the end, would you inject? Thank you.